Pleasure to meet you. I'm delighted to present for the treatment of peritoneal cancer. My name is Gyeonggi, in charge of director in SAM Integrative Cancer Hospital, which is located in Seoul, Korea. My major is oncologic surgery with a subspecialty of laparoscopic surgery. Today's main subjects are the treatment of peritoneal cancer and the presentation of the clinical outcomes of the laparoscopic hyperthermic intraperitoneal chemotherapy. I would like to take this opportunity to share my experiences of overcome the far advanced peritoneal surface malignancy. First, I will present about the pathophysiology and the treatment. Peritoneal carcinomatosis is understood as not distant metastasis, but local regional metastasis. So you will be needed to treat these regions more aggressively. Typically, there are two routes of peritoneal carcinomatosis. First, transserosal growth of tumor. Second, during operation, tumor cells could be spillaged by transection of lymphatics and vessels or manipulation by surgeon. Peritoneal dissemination is established through two different processes. A is transmesothelial process. B is translymphatic process. The peritoneal plasma barrier is a pharmacological entity of importance for treatment of planning in patients with PSM. This physiologic barrier limits the resorption of drugs from the peritoneal cavity into the blood. Also, systematically administered anti-cancer drugs are difficult to reach cancer cells in the peritoneum. So, intraperitoneal chemotherapy must be combined. There are various kinds of ways to deliver chemotherapeutic agent to the peritoneum. The representative one is LHIPEC. LHIPEC is usually performed after cytoreductive surgery is performed. CRS is to remove cancer tissue of the peritoneum as much as possible, and then perfuse the hyperthermic fluid and the chemotherapeutic agent into the peritoneal cavity. Second one is LHIPEC. It's a laparoscopic procedure of LHIPEC. This is my main treatment modality. PIPEC is a method of spraying into the peritoneal cavity by making aerosol with chemotherapeutic agent. NIPEC is intraperitoneal chemotherapy in room temperature. The standard treatment of peritoneal surface malignancy is chemotherapy. But nowadays, intraperitoneal chemotherapy is increasingly widely practiced. The main advantage of intraperitoneal chemotherapy is higher dose than systemic concentration to the peritoneal lesions. These figures shows that higher doses could be delivered to the outside of tumor which are given intraperitoneal chemotherapy. When 43 degrees of Celsius heat is applied to the cancer cells, the hypoxic and acidic environment are changed to hypoxia and high pH level. This makes cancer cells more susceptible to selective destruction of tumor cells. Architectural and vascular changes at these thermal doses lead to increased blood flow, enhanced drug delivery, drug extravasation, and higher oxygenation of the tissue. These changes in the environment of cancer tissue increase the effectiveness of chemotherapy and radiotherapy. Hypothermia can activate the immune system, express the heat shock protein 70 by hyperthermia, activate the antigen-presenting cell, and it stimulates proliferation of cytotoxic T cell. The other hypothesis is histoprotein surface expression occurs in some tumor cells, activating NK cells. The drugs used for LHIPEC should be selected that additively effective. When applied with hyperthermia, representative agents include cisplatin, carboplatin, mitomycin, and doxorubicin. Unlike as 5FU is not used because there is no synergic effect when heat is applied. The drugs administered in the peritoneal cavity have fewer systemic side effects as the AUC ratio increases and penetrate to depths of about 3 millimeters. I will introduce LHIPEC and LHIPEC in more detail. Papers on LHIPEC were first published in 1980. This is schematic diagram of LHIPEC procedure. For this, you will need thermometer, roller pump, filter, heater to heat the water. The photo of light shows that Colosseum technique, a method of LHIPEC. PCI is an important index for evaluating peritoneal seeding. The volume of tumor as assessed by the lesion size score is determined for the 13 abdominal pelvic regions. The sum of these scores 0 to 39 is the peritoneal cancer index. The completeness of cytoreduction score is assessment of residual disease after maximal surgical effort. A major prognostic indicator for the survival in peritoneal cancers. It is divided into 4 grades depending on the size of remaining peritoneal tumors. The mortality rate from CRS LHIPEC were 0 to 9%, and the serious complications occurred in about 27 to 65%. The median survival is approximately 11 months when CRS LHIPEC were performed in patients with peritoneal metastasis from gastric cancer. This result shows similar to those of chemotherapy alone. So in these days, it is preferred to repeatedly administration of anti-cancer drugs into the peritoneal cavity. This is a famous study of CRS LHIPEC performed in ovarian cancer. A randomized comparative analysis study was performed between the debulking surgery only group and the post-operative LHIPEC group. Among patients with stage 3 epithelial ovarian cancer, this additional LHIPEC to interval cytoreductive surgery resulted in longer recurrence-free survival and overall survival than surgery alone and did not result in higher rates of side effects. The result of this study was added to the NCCN guideline. This paper is on the treatment of mesothelioma, published by Sugar-Baker, who is famous for peritoneal surface malignancies researches. This is a method of simultaneously bidirectional treatment with intraperitoneal normal ceramic Alimta and systemic cisplatin was administered by repeating 6 times. The aggressive surgical approach plus regional chemotherapy has increased the median survival to more than 5 years. With an LHIPEC long-term added on, 70% 5-year survival rate has been reported. PROGY-7 is a very famous study, randomized phase 3 multicentral trial. Patients with peritoneal metastasis from colorectal cancer. Patients were treated with cytoreductive surgery plus LHIPEC with oxaliplatin or cytoreductive surgery alone in association with the systemic chemotherapy. The therapeutic management of peritoneal cancer from colorectal cancer by cytoreductive surgery shows satisfactory survival result, while the additive LHIPEC with oxaliplatin does not influence the overall survival. The most significant shortcoming of LHIPEC is that single dose, even with hypersomnia, is not sufficient to allow the anti-cancer drugs to infiltrate into the deep portion of metastatic lesions on the peritoneal surface. And therefore, multiple intraperitoneal doses are needed to result in marked anti-tumor effect on the peritoneal surface malignancies. LHIPEC is laparoscopic LHIPEC. There are 2 main purposes of performing LHIPEC. One is controlling malignant ascites. The second is to be used as pre- and post-operative therapy for peritoneal metastasis. The only study of LHIPEC was published in 2001. All of the publication shows some promising result. MD Anderson Cancer Center present the result of clinical trial on LHIPEC for gastric cancer. The characteristic of this study is that gastrectomy were performed after controlling the peritoneal metastasis by repeatedly performing LHIPEC, which is the same way our center. The median survival was good at 30.2 months, and about 25% of patients reported to gastric resection was possible. The technique of LHIPEC as follows. Set the temperature of inflow solution to 43 degrees Celsius, and the duration is 60 to 90 minutes. Repeat LHIPEC every 4 to 5 weeks. This is schematic of bidirectional chemotherapy for gastric cancer patient. Depending on the regimen, LHIPEC is performing every 4 to 5 weeks, and the systemic chemotherapy are performed between these procedures. This is a table showing the procedures performing in our hospital over the past 10 years according to the various kinds of diagnosis. Gastric cancer, ovarian cancer, and colorectal cancer were most common in that order. And some people performed 10 times. Let's look at the result of LHIPEC treatment for stomach cancer. This is case of a 35 years old female stomach cancer patient. As you can see, the peritoneal lesions were much improved after one session of LHIPEC. Even the mesenteric shortening was slightly relieved after the LHIPEC. As you can see, many peritoneal seeding nodules in the mesentery and peritoneum have disappeared. In this case, the peritoneal metastasis nodules completely disappeared after 2 sessions of LHIPEC. The radical gastrectomy could be done. This study shows the change in the volume of malignant ascites. The amount of ascites decreased by 72% after one session. These are the result of change in PCI scores after repeated LHIPEC sessions. The peritoneal cancer index for gastric cancer decreased by 61%. The median survival of a patient was 12.2 months for stomach cancer patient, except for 13 cases who were taken cytoreductive surgery and LHIPEC after performing LHIPECs. The median survival of the LHIPEC group was 15.8 months. This is safety profile of LHIPEC. Out of 123 cases, there were no treatment-related mortality. There were 6 incidents of adverse events which were grade 3 or higher. Finally, I will present about the malignant peritoneal mesothelioma. There were 18 patients who received the LHIPEC for malignant peritoneal mesothelioma. The survival time of malignant mesothelioma is usually around 1 year, whereas our median survival was 23.5 months. This is a case of a 71-year-old male patient who took 8 repetitions of LHIPEC. At first, the volume of ascites was 6.5 liter, but it was almost disappeared, and the peritoneal lesions improved a lot. Most of the tumors have disappeared. He survived 25 months from the date of diagnosis. 55-year-old male patient was treated with systemic chemotherapy and LHIPEC concurrently. The volume of ascites was 4 liters, but all disappeared, and the peritoneal metastasis almost disappeared. He has been alive for 5 years. You can see that the regions improved as a repetition of LHIPEC. These are the conclusions of my experience. Intraperitoneal administration is essential for the treatment of peritoneal surface malignancies. LHIPEC is a relatively safe procedure that can be performed repeatedly. Although it is not conclusive, LHIPEC have a potential survival benefit in stomach cancer patients with peritoneal carcinomatosis. Also, it is effective in controlling malignant ascites and improving PCI score of patients. Thank you for your attention.